completely different angle. So I'm a physician, a respiratory physician. I do acute medicine at St George's. I'm at the front door every day. I have people about 30, 40, 50 on an average day who come through the door of, with different needs. By managing our community services, we've got to a level where most people who can manage at home usually manage at home with some support. So the ones we see are pretty desperately ill. And today coming in here, the latest St. George's bed state is -93 for medicine. So how do you manage that? We have -93 beds. That means people are sitting in beds in different parts of the hospital and blocking up systems. They can't do, routine surgery cannot be done, and various other things cannot be done, and we can't do much with them. And one of the common solutions has been that we go around and see our patients twice a day, 3 times a day, which we do effectively, but you can't get an illness managed quicker just by seeing it 3 times a day. If somebody has a desperate illness, they need a couple of days' time to get better from that. However much you see them and you try and micromanage them, it's very hard to do. So that's the sort of challenge I'm talking about. So I'll tell you how I would approach that, or my colleagues who are in this sector where we have to actually make rationing decisions on an everyday. We have to choose between patients. We have to choose who should get it, what and why, and then come home and try and get some sleep at night, thinking, have I made the right decision? So you have to have some fundamental principles that guide you to take you through that sort of step. I'm not going to say that they are the best principles, but I think they are things, and as each individual, doctor of whatever description you will become, you will have to make that decision yourself for every patient that you come across. And it's easy at this stage to say that, this person deserves it more than the other person. But when you're standing by the bedside of a patient who's looking at you, and you have a duty of care towards that patient, and the relatives are sitting there looking at you, and you have a group of juniors who are with you on your ward round, and you've got to say something sensible, say something which is not discriminatory. You've got to say something which is logical, which they can understand from, and yet you're not going to do something which is either politically, socially, racially, age-related incorrect. So that's what I'm talking about. Okay, so in the next 10 minutes, I'll tell you how one can live through that. So just to tell you that before I did my respiratory training, I did a PhD in health services research at Warwick Business School. So I had an early interaction with these sorts of issues and concepts, which helps. Not that everyone has to do it. So I'm going to come very quickly from a global perspective. I'm going to talk very quickly about your duty as a doctor and how rationing interacts with that. I'm going to talk about something that Professor Nine said about who should actually make those decisions that we are implementing in our day-to-day life. And I'll probably not touch politics and industry because that would be slightly outside my area. So that is what we're here for. We're here for the universal concept that health is a fundamental human right and that all people of the world should have that. How many of you feel that, this was in 1977, and it goes back another 10 years because in 1967 in the World Health Organization Constitution, the concept was raised that the enjoyment of highest attainable standard of health is one of the fundamental rights. Now, how many of you think that of the 7 billion population of the world, this can be achieved or is achieved currently? What proportion do you think of the 7 billion people of the world who we believe have a fundamental right, and we believe for the last 5 decades that we've achieved it? 1 billion? Perhaps less? fundamental problem that we are sort of dealing with. And the other interesting thing I point out is, is this statement here. So a country's difficult financial situation does not absolve it, note that word, from having to take action to realize the right to health. Now, that should resonate with you. I mean, there are countries where, they don't have governments, and there are countries where there's not enough money to keep body and soul together. But also in countries where, we're looking at 10 more years of recession. The fact that we have no money, morally perhaps, does not give us a right to say, actually, we can do with less. It's a fundamental concept that one needs to, take into account. I don't have an answer to that. So, and again, what is health for all? So, how do you define it? So it could be, if you look at a village in Africa, it could be a simple provision of safe water. And in the middle of London, in UCL for instance, it could be providing the latest, most expensive drug for cancer in somebody who's got a survival opportunity of 5%. So again, the definition is something that is very fundamental that one needs to look at. And again, as Professor Klein was saying, who should have the right to decide? Do we have the right? You mentioned that you would choose an organ in somebody who perhaps has a better chance of doing justice to it. And that's a very fundamentally sound decision-making process. But do we have the right to make that decision on behalf of our patients? So look at what GMC is talking about. So, we have to conform to the basic duties of a doctor. And we are all, as you know, professionally and personally responsible to make sure that we meet the basics of duty of care. So make the care of your patient your first concern. Now this is every individual patient that is in front of you, that is waiting or trusting you to get information to them. You have a duty of care to every patient. I cannot say that I have 30 people to see, and therefore I'm going to leave those 5 people that probably don't need my attention. If anything happens, I'm personally responsible for that, and all of you will be. So that's something that's going to, you have to look at. So, and also you have a duty to protect and promote health of patients. And I know that, Richard, you talk about some more about, health stuff, health of the public. You can't discriminate unfairly against patients. So I've just taken colleagues out of that picture. So if you're making choices which actually is causing or allowing one patient not to receive something that they might view as the best of care or someone else might, are you getting into the realms of discriminating against a patient? Are you discriminate against patients on the basis of that they're alcoholics, or that they are chronic smokers, or they don't take their drugs? Are we in a position to be able to defend ourselves in that situation? And again, never abuse your patient's trust in you or the public's trust in the profession. Leave the public's trust in the profession for now. So yesterday I was examining for membership, and we had a scenario where we were telling people to say that if you have a CHAD VAS score of 2, then you have a 4% risk of getting a stroke in 1 year. Now, this was a scenario. We asked our examinees to explain to a patient's relative what that meant and to advise them on anticoagulation. And every time they said 4% risk of stroke versus 10% chance that they would fall over and bump their head and have a subdural hematoma, the surrogate was instructed by us to say, that's not good enough. 4%, what is 4%? Doesn't mean anything. So one of our candidates came up and said, she didn't even look at that scenario, and she said, your mother has an 80% chance of dying of a stroke. And if I give anticoagulation, then she'll be saved. Now, immediately the surrogate agreed with that and said, oh my God, 80% chance of stroke, that's good enough. In that case, forget about the risk of falling over and breaking their heads and stuff. That's great. Now, that was wrong. That was completely incorrect. That candidate was failed miserably in the exam. But the point was made. That is the one candidate who got a point across, but she just made up the numbers. That's the sad part of it. But again, you see, these things you have to take into account. So my sort of journey into medicine started, that's why I'm talking about global perspective. That's a Calcutta Medical College, which is pretty old, about 150 years, 160, 170 years or so. And that's in Calcutta, which is economically, still now, pretty poor place. So I'll tell you a couple of things that we did as early exposure to rationing. So I'm a house officer in a coronary care unit, and you're given 3 streptokinase injections per day to manage your patients. Okay? Streptokinase currently costs £1.50. Those days it used to be very much. It used to be equivalent to about 3 times the monthly salary of an average Calcutta resident. So we were given 3. The average number of admissions to coronary care unit on any day would be about 20 or 30. So 30 people would come in with ST elevation MIs who had to be treated with 3 streptokinase injections. That was all. The hospital could only afford that. So how did we manage that? How did you manage that? You're standing there 9 o'clock. By 9:15, you've exhausted your streptokinase. So you have to make a choice. And you have to look at somebody and say, okay, this guy is 67. He's had a stroke before. He's got renal failure. He's got diabetes. He's coming with an MI. He's got no family. The next one is a 40-year-old banker who perhaps could afford it himself. Has 2 small kids. Is it morally right to make that choice? So you know what we did? We came up with a clever solution, which is we told everybody they had to go and buy it. So, most people couldn't buy it. But there could be people, if you tell them that this is something which is critical, which streptokinase is, and makes a huge difference in survival, some people will go and find some money from somewhere to buy it. So we gave the streptokinase when they came in, and we made them go and buy it. And then we replaced it. And that way, we found 10 or 12 streptokinase injections. So 50% of our patients were done, were treated. Now, everybody knew that they had to buy it, but the ones who couldn't, we were giving them the ones we had stocked up. So, is that morally right? I don't know. But we felt good that we managed to treat more people in that way. So, again, I'll tell you a simple decision. St. Mary's Hospital here, as a registrar, we had somebody in intensive care. We suddenly discovered, a 75-year-old chap, discovered that he's got metastatic cancer. We had no idea that he had that. It was discovered after he was ventilated. And his son came up from somewhere in the US, and he said, we've got to treat him fully. We've got to give him chemotherapy and radiotherapy while he's on a ventilator. And imagine that discussion with that person. We're telling him, look, the chances of survival are less than 5%. The chance that this would be amenable to any chemotherapy or radiotherapy is probably less than 5%. We made up the numbers. We were not sure, but it's not very far from that. And then he said, I think 5% is good enough. My dad would love to have even that opportunity for living. What do you do then? How do you manage that? He's telling you, 5% is good enough for me. We had to work hard to convince him that would not work. So, again, the basic question, I'll run through quickly. Patient or the public, who should be choosing? Because when you look at an individual patient, that patient has a priority, like this one had. To him, that was important. To his family, that 5% was important. But by giving him chemotherapy in an ICU bed for next 6 weeks, how many other patients will be denied the opportunity to survive from their pneumonias and their renal failures and others? Is that a fair choice to make? Should a patient make that? Or should the public make that decision? Yeah. So just move quickly to the Oregon plan. So this was about US state deciding that we will want to do it in a very fair, democratic way, and we would give free healthcare or insured healthcare to a group of people, but the people will make those choices. So, as in popular way, Americans decide on how they select their presidential candidates. They had public meetings, they had town meetings where people were given choices, and they were given an opportunity to discuss, and they decided how they would weigh and how they would value the individual conditions and treatments that were available. Out of a 700 item list, they chose about 300, which then they decided to fund. So people in that group, people with those conditions would be funded, but the majority would not be. And they also ranked the diseases and treatments purely based on universal choice or public choice. Now, is that a good way of doing it? At that stage, they felt it was a very good way of doing it, and it would be the most fairest, most democratic way of doing it. It didn't work out well, because the overall effect was those people who had no health care at all were given access to some treatment. The people who were in the sort of middle lost some of the treatment that they could have got. And the people who could afford treatment, they were not touched by this at all. And what eventually happened is that people were unhappy. So the rare diseases, the multiple sclerosis, the other chronic conditions where quality of life can be debatable in those times, they decided this is not good enough. We need to be working hard on this. And so there were lobby groups and patient groups who started to lobby that. Democracy didn't work in that sort of situation. So NICE, you all are aware of. NICE uses a quality metrics for deciding on its treatments. We have great faith in that. NICE is probably one of the best ways currently devised of how to do this. And what it does is that it looks at cost effectiveness and puts a threshold on the quality adjusted life year gain. At present, the threshold is about 20 to 30,000 per quality gained. I won't go into that at this stage, but what the problem with that is NICE will have a lot of people who believe in it, and there are a lot of detractors of NICE and who don't believe in it. And individual choice or patient autonomy is something that often gets into a fight with a decision that NICE takes. And you hear lots in the news about how this happens. And because NICE bases its data on RCT level studies and cost effectiveness, what happens to diseases where we don't yet have that quality of data, where there are rare conditions, orphan diseases as we call them in respiratory area? What happens to that? How do you put quality metrics onto that? At present, I don't think there are better ways yet, but that is currently the way that UK and much of Europe is looking at. So the choices we have for our discussion later is individual right to best health, which is a fundamental human right, versus affordability, and that is different to different countries. Should thresholds change now that we can't afford the healthcare that was affordable 10 years back? Should we now change it? Say that we can't do this sort of stuff, but when we are better off, we will do it. Should that change? What happens to the people who fall below the line at this stage? And are we discriminating against individual patients? How do you stand in front of a patient and make that choice? Something that you guys have to think about. Individually, you have to think